Welcome to the Gyan Pravah episode number 254, the show where we dive deep into the ideas, people, and policies transforming healthcare in India and around the world. I'm your host, Dr. Sunita, the chairperson of the Fogsi Gynecological Oncology Committee, and your host for the 9th of every month. In today's episode, we explore one of the most far-reaching and impactful healthcare collaborations in the country, the National Cancer Grid. This podcast series has been initiated by our president, Dr. Sunita Tandulwadkar, who is a visionary leader of Fogsi, started with this year's theme of Ek Rashtra, Ek Mission, Swasth Nari Samriddh Vatan, Har Ghar Fogsian, which resonates deeply with our mission to empower women and enrich lives. Through her impactful initiatives like Know Your Numbers, Sampurna, Swasth Janma Abhiyan, Aprajita Sampurna, Do Teeke Zindagi Ke flagship Eagle project, Arogya Yog Yatra, Gyan Pravah, and Fogsi Anuban, along with 7 publications, the Arogya Sakhi app, we are weaving a strong and inclusive fabric that connects every Fogsian to the heart of the association. These efforts ensure that each member feels valued, involved, and an integral part of our shared mission. Some initiatives for women's cancer are the Do Teeke Zindagi Ke project for cervical cancer, launched on World Cancer Day, the Fogsi IMA project on training 50,000 IMA doctors on HPV vaccination, the Nirmal Banaras Abhiyan for HPV testing, the Wave 2 educational program for Fogsians on evolving science of HPV and newer techniques to handle myths to train 25,000 Fogsians on HPV vaccination, the Swasth Nari Abhiyan Yatra, and there are new programs being launched every day. Cancer in India has long faced the challenge of inequality, with treatment quality varying widely across regions. But the National Cancer Grid, or NCG, is a mission to change that by creating a network of over 300 cancer centers working together to provide uniform, evidence-based, and affordable care for every patient, no matter where they are. So in today's podcast, we are honored to be joined by the visionary behind it all, Dr. C.S. Pramesh, the convener of the National Cancer Grid and director of Tata Memorial Hospital in Mumbai. Welcome, Dr. Pramesh.
Thank you. Thank you very much, Dr. Sarita. It's a pleasure to be part of this podcast, and thank you for inviting me.
So let me introduce Dr. Pramesh to you first. Dr. C.S. Pramesh is the director of the Tata Memorial Hospital and professor and head of thoracic surgery at the Tata Memorial Center, Mumbai. He has been serving on the UICC Board of Directors since 2020. He is the convener for the National Cancer Grid, which is a large network of close to 400 cancer centers in India. The mandate of the National Cancer Grid is to provide uniform standards of cancer care across the country. Dr. Pramesh is highly committed to efforts towards reducing inequalities in cancer care and making cancer treatment accessible to all geographic regions and strata of society. He is the recipient of the prestigious Rachel Perlline Global Cancer Research Humanitarian Award from the National Cancer Institute, USA. He is visiting professor at the Division of Cancer Center, King's College London, the Institute of Cancer Policy, King's Health Partners London, and the National Cancer Center, Graduate School of Cancer Science and Policy, Korea. He serves on the advisory boards and task forces of several national and international research organizations and granting agencies, including WHO, ASCO, ESMO, and UICC. His clinical interests include the management of esophageal and lung cancers and minimally invasive surgery. He is the principal investigator in several investigator-initiated research studies, including randomized trials on cancer screening, surgical techniques, neoadjuvant and adjuvant treatment of thoracic cancers. His research interests include health services research, value-based care, addressing barriers to access and cancer policy. He has more than 300 peer-reviewed journal articles, abstracts, and book chapters on various topics, including thoracic oncology, clinical research methods, translational research, cancer policy, and health disparities. He also has strong interest in clinical trial design, surgical trials, comparative effectiveness research, promoting collaborative research, health services research, and cancer policy. He's in fact done his postgraduate diploma in clinical trials from the London School of Hygiene and Tropical Medicine, University of London. He is keen on promoting training in clinical research methods and conducts several courses on clinical research methodology, biostatistics, and scientific writing. So Dr. Pramesh is not only a globally respected surgical oncologist, but also a tireless advocate for equity in healthcare. He is leading one of the most ambitious cancer care initiatives in the world right here in India. So in this podcast, we'll talk about how the cancer grid came into being, how it's transforming outcomes on ground, and what it takes to lead such a massive collaborative effort in one of the world's most diverse healthcare systems. So thank you again, Dr. Pramesh, for joining us.
Thank you. Thank you very much for having me here.
So let us start with, tell us something about yourself and what made you actually change gears from a surgeon to a policymaker.
So I spent the first half of my life in Coimbatore, where I did my schooling and undergraduate medical education. And for the last 30 years, I have now been in Mumbai, where I did my post-graduation, my subspecialty training in initially surgical oncology and subsequently in thoracic surgical oncology. And I've been at the Tata Memorial Hospital for over 25 years now. And as my career has progressed, I've gone through various stages of what I'm passionate about. Initially, it used to be cancer, thoracic surgery, and the actual practice of clinical oncology. But over the last more than 10 years, I have expanded from just being a clinical doctor to trying to influence some of the pressing problems that we have in society today, which is disparities in healthcare access, and in a more limited way in the area that I work in, access to cancer control. And I use cancer control consciously because it cannot be limited only to treatment, but also to the entire spectrum of cancer control, starting from healthy lifestyles, prevention, screening and early detection, diagnosis, staging, right up to palliative care and survivorship. So it's been a interesting journey.
Yes, that's really, really motivating for everybody. So what was the original vision behind this National Cancer Grid, and what problem was it actually trying to solve?
So the main problem that we were grappling with more than a decade ago, probably for a much longer time, has been the variability in the standards of care that we are able to offer our patients with cancer. So if you look at some of the top cancer hospitals and departments of oncology providing care in India, they would parallel some of the best in the world. But the variability in care between the high-performing centers and the not so high-performing centers is what stands in the way of every individual with cancer diagnosed in India getting the same access to care. And we realized this when we created a heat map of over 75,000 patients who visited us at the Tata Memorial Hospital in Mumbai. And what we realized was that less than 30% of our patients actually came from the state of Maharashtra. About 70% of them came from very far distances, often traveling thousands of kilometers. And all of us know the difficulties of traveling and living in a city like Mumbai, which is quite an expensive city to live in, with the result that many patients actually ended up not completing their treatment. As clinicians focused on providing medical care, we very conveniently call this as treatment abandonment. I don't think any patient would want to abandon treatment. It is a failure of the healthcare system. It's a failure of us as professionals offering cancer care that we are not able to create an enabling ecosystem where patients are able to complete their treatment and get their best chances of cure. So this was the primary motivating factor for creating the National Cancer Grid in 2012. But also the fact that the human resources available to treat cancer in India were much short of what it needed to be in an ideal situation. And the fact that we did not have a platform or a network of centers which are capable of multicentric, multidisciplinary cancer research. So these were the three main pillars on which the Cancer Grid was created in 2012. But to me, still the primary motivating factor is to reduce the inequities that we see in access to high quality evidence-based cancer care.
Yes, absolutely. So I know it's such a diverse country. And how did you, the standardizing cancer care also, it must have been very challenging, which is a country as vast and diverse as in India. So how did you begin to build a consensus on what standard of care should be like? And how do you ensure that with so 300 centers, how do you ensure that protocols are not only developed, but they're actually followed on ground?
No, these are very good points. And to be honest, this is still work in progress. Uh, the truth is, we are working towards uniform standards of care. We have made significant progress in some areas, but we still have a long way to go before we can claim that somebody in rural India gets the same high quality care that somebody in urban India or in some of the top cancer centers in the country would get. What we started was in 2012, we invited the directors of the 29 regional cancer centers that were existent to brainstorm on how we could approach this problem of inequitable access. Again, there was quite a bit of skepticism at the beginning, and out of the 29 directors that we invited, only 17 of them actually ended up coming for the meeting. But what we broadly agreed upon was the fact that we needed to work together and create a network which would then start several initiatives towards that final goal of uniform standards. One of the early initiatives that we took was a situational analysis at that time to see what was the ground reality that and the priorities that we needed to identify. And we brought this out as a series of 3 papers where we looked at the demographic profile of patients with cancer in India, the research priorities for cancer in India and as it related to global priorities. But most importantly, how could we get access and accessible, affordable care to all its citizens, regardless of their socioeconomic status, their geographic location, and their ability to pay. So we've taken several steps towards that. The first one being to have uniform standards of protocols. So in 2017, we had our first round of creating the NCG evidence-based guidelines for treatment of cancer in India. But what we realized as soon as we brought out that edition was the fact that a single set of guidelines would not be fit for purpose for a country as large and as diverse as in India. And we needed to look beyond just hardcore clinical evidence. We needed to look at feasibility of administration of care. We needed to look at affordability. We needed to look at human resources and the expertise that was available and the infrastructure that was available for care. So the second edition, which we brought out in 2020-21, was resource stratified. So now we have 3 sets of guidelines. The first, which is optional, which means that, so let me start from the other end. So we have the basic set of guidelines called the minimum set of guidelines, without which a cancer center should not be treating these kind of patients. So very common cancers, less complicated treatments can be treated anywhere, and we want this to be available at the doorsteps of patients diagnosed with cancer, so that even smaller centers, less resource centers are able to treat these common cancers. The next level of evidence-based guidelines was the optimal set of guidelines, wherein in addition to the minimum, we were looking at evidence and make sure that we brought cost effectiveness into the picture as well as the evidence. So something which was marginally effective but extremely expensive would not be part of the optimal guidelines. And this is where we feel that between the minimum and the optimal guidelines is where public healthcare expenditure should be going towards. But nevertheless, we also realize that a lot of patients are extremely wealthy. They wouldn't mind spending a lot of money for even marginal benefits of care. And we want our guidelines to be inclusive for them as well. So we have what we call the optional set of guidelines, which is the highest level, which would be far closer to the NCCN guidelines or the ASCO guidelines, where we take pure efficacy of the treatment into consideration with no consideration to cost effectiveness. So you could potentially have something that is marginally effective, which could prolong life by a few weeks or months, which is very expensive, but they would form part of the optional. But we don't feel, given the public healthcare budget that we have, that this should go towards treatment of these kind of treatments. We should be prioritizing it to make sure that we get the best value for the money that the government spends.
Absolutely. I think that that's definite. That's more practical for a country with so much different economic, with so much economic disparities all across. So how does collaboration across the grid actually look like? Is it with regular meetings, shared platforms, joint research?
Right. So the answer to this is through all of these mechanisms. And I think if you were to ask me one single reason why the National Cancer Grid succeeded in the way that it did, it is the fact that it has been an extremely participatory, very inclusive, grassroots level movement. This is not a top-down movement with a top health official telling the rest of the country how to treat cancer. This has been a movement which has been initiated from the healthcare providers, from the cancer hospitals, the NGOs which work in cancer, the patient groups. Everything that we do has a patient voice in it. So we make sure that all the stakeholders who are involved in this, including research institutions, cancer hospitals, patient groups, professional societies, are part of this movement. And each of these initiatives, I can think of at least 20 initiatives that the Cancer Grid has undertaken in the last 12 odd years. Each of these 20 initiatives has been based on a real stated problem coming from somebody who's affected by cancer. It might be a hospital, it might be a patient, it might be a professional society. They've identified the problems and we brainstormed together purely as a collaborative group to try and address those problems in the most effective way.
Yeah. So, and how does the training and capacity building, how do you manage that? How has it, how has the NCG transformed the workforce development in oncology, especially for nurses, technicians, and support staff?
Right. So this is an extremely important component of how we are planning to address the system. So there was an Ernst & Young report, actually two Ernst & Young reports in the last decade, which looked at what is the existing human resource to treat cancer in India and what is the ideal given the current situation, not even taking into account the projected increase in patients diagnosed with cancer over the next 20 years. And what we realized was that there was anywhere from a 1.4 time to a 2.6 time increase in the number of cancer professionals that we require. Now, getting trained human resource to that extent cannot happen overnight. So having realized that, what we are working on is multiple approaches. One is on task shifting and task sharing. How can a doctor's time be most optimally used by sharing some of his or her requirements or his or her work with people who might not be medical professionals, but can perform the same task with as much, if not better, efficiency. So that's one approach that we take. We also have identified certain systemic problems in how continuing medical education happens in India. So if you were to look at locations like Northeast India, where a large proportion of patients with cancer exist, in fact, the incidence in Northeast India is 2.5 times the national average. The workforce that is available there is much smaller than it should be. And the fact that they are in such remote locations, it could take even professionals anywhere from 12 to 14 hours traveling from Arunachal Pradesh to cities like Mumbai and Delhi for attending medical conferences. The reality is that very few of the professionals treating cancer from these regions actually visit or participate in cancer conferences across the country. So having realized that, what we did was to flip the learning system around. Instead of expecting them to travel to Mumbai, Delhi, Chennai, Bangalore, Hyderabad for conferences, we send a group of experts across multiple remote locations in Northeast India and several other parts of India now subsequently, where we run workshops. It's kind of like a road show or what we call a traveling school in aspects like pathology, in oncology nursing. We hope to start this in palliative care and community medicine as well, where the experts from the National Cancer Grid centers run a series of workshops, meetings, and conferences close to these locations. So in fact, we did this in 11 cities in Northeast India over 26 days, and we're able to impart continuing medical and nursing education at the doorsteps of these individuals, something that would be out of their purview if this wasn't to be so. And therefore, we were able to democratize access to medical education. The final part I want to mention about capacity building in India is to promote very specific training opportunities for members within the National Cancer Grid. So we have funded fellowships where we fund individuals who want to get trained in very specific areas of cancer control. It could be something like, how do we do HPV screening? How do we counsel individuals for HPV vaccination? It could be, how do we get patients from who are diagnosed to complete their treatment? For someone who's already a qualified surgeon, how do we get trained in minimal invasive surgery? So we offer funded paid fellowships to enable these individuals to build on their own expertise and to get better at the kind of cancer control activity that they are providing.
Right. I think that's really wonderful, actually, all the work that you're doing. Are there any standard partnerships or institutions that have been particularly pivotal in scaling up the grid's impact?
So I don't want to single out names because this has been a truly community-led or a stakeholder-led activity. But I must mention here that we have had enormous support from the most unlikely of sources. So typically you would expect that centers like Tata Memorial, centers like Cancer Institute Adyar, like Kidwai, the Gujarat Cancer Research Institute, the aims of the country would drive many of these initiatives. Nothing could be further from the truth. We've had pivotal initiatives coming up from very small centers because personally I feel they stand to gain the most out of an initiative like this. And the fact that there's so much to gain, there are opportunities for improvement in the processes and functioning that they are able to bring to their respective organizations has driven this. But again, I would say that this has been a grassroots level movement, multiple centers, and I would be doing a disservice if I were to single out a few institutions alone. We've had tremendous support from the member organizations.
That's wonderful.
But again, just to elaborate on that, I'd be failing in my duty if I were not to mention the support that we've had from the government over the years. So what happened, and I'll give you an example of the resource stratified guidelines. So what happened was that the one of the annual meetings where we launched the resource stratified guidelines was actually attended by the leadership of the National Health Authority, who without hesitation agreed to link reimbursement under the ABPMJ or the Ayushman Bharat scheme to adherence to the NCG guidelines. So what this does is automatically bring in a level of quality which would otherwise not have happened, because we all know that having guidelines is one thing in India, to actually enforce them and implement them is something entirely different. But by linking them to reimbursement under the Ayushman Bharat scheme, what we have effectively done is to ensure that everyone who's treated through the scheme gets evidence-based care. So this is just one example of how we work with the government. We work closely with the Indian Council of Medical Research, where we collaboratively, after we identified 5 key research priorities for cancer control in low and middle income countries such as India, we partnered with the ICMR where we matched funding. The NCG put in X amount of money, the ICMR matched it with another X, so that we were able to double the research grants that we were able to provide to principal investigators from across the NCG centers. And I'm happy to say that several potentially practice-changing clinical trials have been launched based on this collaboration between the NCG and the ICMR.
So how does data collection within the grid improve the understanding of cancer patterns in India?
So this has been one of our very initial ambitions, to have a unified portal wherein data can be aggregated. Having said that, this has again not been an area where we have had very high levels of success. The problem being that most centers in India still depend on pen and paper for medical records. The last time we did a survey of the NCG centers, only 1/3 of the centers had electronic medical records, which makes aggregation of data difficult. And even within the 1/3 of the electronic medical record solutions that we have, or the hospitals that have electronic medical records, these medical records don't talk to each other. So you could have one system, we could have another system here, and a third hospital could have a third system. Though all the data is digital, we've still not cracked the problem of how can we share data without manual extraction and putting it into a database. Having said that, we ran a pilot thanks to funding from the Department of Biotechnology, the BIRAC mission, wherein we were able to demonstrate that in a small group of 10 high volume cancer centers, we were able to collect data, though it was extracted manually, in 5 of the most common cancers. And we've got a large data set of patients who were diagnosed with these 5 common cancers in these 10 centers. So that was a proof of concept. But what we also realized was the fact that this was not the most efficient way of aggregating data. So thanks to a new center that we created called the Koita Center for Digital Oncology, generously funded by the Koita Foundation, and I'll take this opportunity to express my deep gratitude to the Koita Foundation. I know the foundation is working with Fogsi as well. They have signed an MOU with Fogsi recently. Thanks to the Koita Center for Digital Oncology, what we were able to do was to create a wish list of what are the criteria that should go into a ideal electronic medical record, which was fit for purpose, not just for a general hospital, but had some oncology specific modules as well. And one of the areas that we're working with is to make sure that the data elements that are collected through the empaneled vendors, and I'll come to in a minute about how we empanel these EMR vendors, so that it's possible to passively extract the data that the ICMR hospital-based cancer registry requires without manual intervention. So now this is a dramatic improvement that will come on to how we are able to collect data, because you're taking the human element out of it, with human beings being involved in extracting data and then populating an electronic database. You have several problems. One, it's not scalable. And 2, you're bringing the element of human error. By being able to passively extract data from electronic medical records, you're eliminating both of these problems. So as soon as we identified these ideal criteria of what goes into an electronic medical record, we floated a public tender. We had expressions of interest from close to 20 EMR vendors. We went through a very rigorous process of evaluating them. We shortlisted 13 out of the 20 EMR vendors, and out of the 13, we empaneled 6, which came closest to the kind of criteria that we had as an ideal EMR. We didn't stop with just identifying and empaneling these vendors. We went ahead and we continued to work with these 6 empaneled vendors to refine their product even more and make it better than what it originally was. And again, to promote adoption of electronic medical record systems by hospitals, we were able to generate some CSR funding and partially support hospitals which wanted to adopt the digital route. So we are able to provide substantial funding for hospitals for government and charitable hospitals which volunteer to get to include electronic medical records into their medical record system, and we partly fund them. So we've been able to create an ecosystem where the quality of the electronic medical records are improving. We are promoting adoption of digital health by hospitals across the country, and hopefully with all of this and the NABH coming up with digital health standards, we would have effectively created an ecosystem which feeds into the Ayushman Bharat digital mission, which has this grand goal of making sure that all medical records are digitized and are available in the electronic format.
Yes, I think that would be really wonderful to have a seamless transmission of data across centers wherever the patient goes. So what have been your challenges, leading such a massive and critical initiative? This, I'm sure it comes with a lot of challenges. What have been the biggest roadblocks and how have you navigated them?
So I think the biggest challenge, especially at the initial phase of the creation of the cancer grid, was the kind of skepticism that most people, and I would say most people rightfully had, about whether something like this would really work, whether a network of this nature would be possible, sustainable, feasible. Primarily because something like this had never been attempted before. We've had professional societies coming together which have worked very well, but rarely have a combination of government, charitable, and private hospitals come together, working with NGOs, working with patient groups, professional societies, charitable organizations. So very naturally, there was a lot of skepticism about whether something like this would work. And the initial phase of becoming members of the NCG was fairly slow. But we were able to overcome this by starting slowly, but making sure that our initiatives were impactful, they were of benefit for all our member organizations. And now it's reached a velocity which is on autopilot. I don't think we need to convince organizations that of the benefits of being part of the National Cancer Grid. But having said that, I must say that there have been areas where we have not succeeded as well as we would have liked to. The data aggregation problem, which I just described a few minutes back, is one of them. The other part where we didn't succeed as much as we would have wanted to was in group negotiation for equipment which go into cancer centers. So a few years back, very naively, we thought that if we were able to aggregate demand and procure equipment in bulk from equipment manufacturers, we would be able to substantially bring down costs of equipment. So instead of a center tendering for one CT scanner or one MRI or one ultrasound equipment, just imagine the power of negotiating for 50 PET scanners, 80 CT scanners, whatever number of ultrasound machines and so on. Unfortunately, this didn't work because industry was able to convince individual hospitals that the generic kind of specifications that we had as part of the National Cancer Grid would not suit what their requirements were. And they were able to break down this collated demand into multiple smaller requirements. So we didn't succeed very well. But we learned from our mistakes. And the next time we did the pooled procurement, we decided that we would go in for something which was not so specification heavy. So we decided to go and negotiate for medicines that are commonly used in treatment of cancer. And I don't mean just chemotherapy and immunotherapy medicines, but also antibiotics, colony stimulating factors. What constitutes the large part of a hospital which treats cancer as their pharmacy budget? So we collated demand from multiple NCG centers and negotiated with the pharmaceutical industry as a group. So we've done 2 such cycles so far, and the kind of discounts that we've been able to get ranged from a minimum of a 23% discount to a 99% discount on MRP with an average discount of 85% on MRP. So effectively, for those drugs that we've negotiated, the cost of the drug becomes 15 rupees when the MRP is 100 rupees. So dramatically bringing down the costs of cancer care for our patients. And so it's been a lose some, win some, learn from your mistakes kind of an approach. I wouldn't remotely suggest that everything that we've started has been successful.
Right. So what was the most unexpected lesson from your journey with the grid so far?
There have been several lessons that we've learned. To me, again, the most important lesson is the power of working as a group. Again, none of this would have been possible if it was if there were a few centers driving these initiatives and expecting the rest of the country to follow. It has been entirely a community-driven, grassroots-driven movement, which, as I mentioned earlier, has been key to why these initiatives succeeded. The second lesson that I would want to suggest is that we so often as policymakers, we go with a solution and then try and find a problem that the solution fits. We did the exact reverse. We found a problem and then tried to identify a solution which would fit that, which again was driven by a lot of discussion, getting to know what the ground realities were from the workers who are actually on the ground, and trying to identify and find solutions for that. And finally, as I mentioned earlier on as well, not get shackled by what we typically expect to happen. As I mentioned, some of the small centers have contributed so much to all of these initiatives that to kind of relegate them as people who may not be able to contribute is a very big mistake, which many of us are probably guilty of. And to it takes a small group of committed individuals to make something work or not work. And I wouldn't underemphasize the importance of these group of extremely passionate people and with a lot of commitment.
That's wonderful. But how do you stay motivated in this field that involves a high stakes and slow systems change?
I think the key is to be patient. Nothing happens overnight, but even if you're able to move the needle in small ways, but do it at scale. So if with a country as large as India, even a 1% or a 2% improvement in survival, a 2% reduction in peri-treatment morbidity and mortality, a 5% improvement in early detection will have such a big impact because we are 1.4 billion people. And it's difficult not to remain motivated. I would say the problem is the reverse. We would want to do so much more, and sometimes we lack the bandwidth to be able to do that, which is a bigger problem than getting demotivated at any point. I think this is a self-perpetuating motivation that drives the entire team behind the scenes at the Cancer Grid. And again, I must say that this has been a huge team effort by a fairly large number of people. Nothing of this would have succeeded without this team working behind the scenes.
That's fantastic. So what's next for the Cancer Grid? Are you looking at primary prevention, palliative care? You did mention digital health integration. And the next, if we fast forward 5 years, what is one change that you'd like to see across India's cancer landscape?
So I think you hit upon most of the points that the Cancer Grid is looking at. Again, we were late in starting our health promotion activities, but we have again a very committed group of individuals who are working on health promotion, and a very diverse group. They're not just clinicians, they are NGOs, they are behavioral scientists, because we know that health promotion, adopting healthy lifestyles is not just telling people don't use tobacco or alcohol and live healthier lifestyles. Even the communication skills that are required, the way we communicate these ideas is important. So we've got a very diverse but expert team working on health promotion. The other extreme of what we are looking at is in palliation. And unfortunately, though the Cancer Grid has emphasized the importance of palliative care getting integrated into cancer care, and in my view, it's not just cancer care, with many chronic illnesses. Unfortunately, leadership of hospitals and healthcare providers have not yet created the necessary infrastructure and invested the right amount of resources, and here I mean both financial as well as human resources, into promoting palliative care. And given the fact that the vast majority of patients diagnosed with cancer in India come at a very late stage, I think this is an extremely important initiative which would be a lost opportunity if we were not to pursue it. So we're just now in the process of evaluating a pilot where we will fund 5 hospitals, and we will go through a very rigorous selection process of identifying these 5 hospitals. And we'll actually fund them in creating palliative care departments or units within their hospitals, which will then prove to be a kind of an exemplar and a demonstration of what does it take for a hospital to create a palliative care department or a unit. And we are hoping that with this pilot and the success that this pilot will have, that more and more hospitals will adopt this. The next area that we are focusing a lot of our efforts on are in digital health. The EMR example was just one example of what I meant by digital health. We are also, with the Koita Center for Digital Oncology, working on creating teleconsultation platforms which are efficient. Right now, teleconsultations are just a fraction of what they could be, primarily because the entire process is very clumsy and it's not user-friendly either for healthcare providers, physicians, or for patients. So we want to create a solution which makes it easier for everyone concerned, so that in the most efficient way we are able to offer teleconsultations. We are working with MeitY, the Ministry of Information Technology, and their India AI mission to see how we can leverage artificial intelligence, especially now with the revolutions that we have in AI with large language models, as to how we can leverage that to leapfrog many of the advances that that high-income countries have made, but do so in a much shorter time frame. And in fact, we just closed a grant call in collaboration with the India AI mission, where we called for proposals from teams constituted by both clinicians treating cancer, but also technology partners to come up with AI solutions to see how we can take this forward. So these are some of the initiatives that we are looking at. And coming to
Right.
the next question as to how we see the NCG in 5 years' time, what we hope to achieve at the end of these 5 years is to create a culture of quality and safety as an integral part of every aspect of healthcare that is provided. It is peripheral right now, but what we hope to achieve over the next few years is to make sure that it is in the DNA of every individual, every stakeholder involved in healthcare. Not just healthcare, in health as well, because if you are able to prevent and eliminate most of these diseases, the downstream effects of having to scale up your healthcare ecosystem there is less pressure on that. So at every aspect, to make sure that we don't just pride ourselves on the numbers. We will always have numbers because we are a 1.4 billion population, but also pride ourselves on the quality of care that these 1.4 billion people in India are able to get, and to make it equivalent to the kind of quality care that is available in most high-income countries.
Yes. So I think that you've been working so hard. So how do you how do you feel like as a convener? And you must be, feeling the huge responsibility every day. So what message would you like to share with the young oncologists, healthcare professionals, and policymakers who may be listening to this podcast?
So I don't think I'm in a situation where I'm doling out advice. I'm far from it. But some of the lessons that we have learned through this entire journey of the Cancer Grid are the following. We get overwhelmed and daunted by major healthcare problems or health problems, and we take the easy way out of saying that let me just treat the patients who come to me, and I'm fulfilling my duty as a doctor. To me, one of the key lessons I've learned is that every major initiative starts with a small step. And if you were to ask me 13 years back when we started the Cancer Grid whether even 1/10 of what we've achieved so far was in our ambition list, I would have said no. We broke it down into much smaller problems, chewable problems, so that we were able to do that. So one lesson is not to get overwhelmed or feel daunted by problems at scale. Most of those, when you break them down into smaller problems, are solvable problems. And the second and probably the last bit of guidance that I could potentially give is to make sure that you're not afraid of making mistakes. If we had got worried about the kind of mistakes that we would make with many of these initiatives, we would never have started any of these. So we made mistakes with the pool procurement on equipment, but we used the learning from that mistake to go ahead and do an extremely successful pool procurement of medicines. So again, many of us don't take up major initiatives because of the fear of failure. In my mind, somebody who has never failed has never aspired enough and not been as ambitious as they should. And here I use ambitious in a very nice way about achieving some of the goals that we set out to achieve. So the fear of failure should never get into the way of that.
Yeah. So how do you think, Fogsi can work with the National Cancer Grid? And what message would you give to the all the gynecologists across India?
I think given the fact that gynecologists treat a lot of cancers in India, and here I'm not just restricting it to hardcore pure gynecological cancers. We know that a large number of women with breast cancer actually feel more comfortable visiting their gynecologist than a general surgeon or or a cancer surgeon or an oncologist, I think the opportunity for working together between Fogsi and the National Cancer Grid on areas of prevention of diseases like cervical cancer, early detection, screening of gynecological cancers, and even to some extent breast cancer are areas that we could potentially work with. We would absolutely love to have Fogsi representation on the guideline committees of the gynecological cancers that we are in the process of revising. Fellowships and training opportunities where gynecologists involved in treating cancer can then get matched with cancer centers of excellence. And I did mention about the fellowship program that we have. This is an opportunity for us as a collaboration that we could match Fogsi funding for training opportunities if there was interest on both sides. And at least from the NCG side, I can commit to the fact that we could have an equal number of funded fellowships as Fogsi is willing to fund, which could then be selected through a joint NCG Fogsi selection process, identifying priorities for training in gynecological cancers and so on. And finally, given the large network that of individuals that Fogsi has, this would be a great opportunity for research into gynecological cancer. So at every aspect, whether it be health promotion, prevention, early detection, coming up with treatment guidelines, actual treatment itself, human resource capacity building, research, digital health, all of these could be areas that we could work together. And personally, I would be disappointed if we are unable to do so. And I'm fairly confident with the leadership at Fogsi that we will be able to work together on common priorities.
Yes, sir. Thank you so much, Dr. Pramesh. So that was Dr. Pramesh, convener of the National Cancer Grid and director of Tata Memorial Hospital, sharing deep insights on how strategic collaboration, standardization, and equity can actually truly transform cancer care at scale. So his leadership reminds us that solving complex healthcare challenges doesn't require reinventing the wheel. It just requires connecting it. So if you'd like to know more about the Cancer Grid, you can go to the website and you can follow this podcast, this Gyan Pravah episode, and leave us with a review and share it with colleagues or anyone passionate about improving healthcare access and quality. So thank you so much, Dr. Pramesh, and thank you all for listening. Until next time, I'm Sunita signing off. Thank you so much.
Thank you. Thank you very much for having me here. Thank you.